and warm welcome to all the participants here for the webinar of the Virudhunagar District Pediatric Forum. In fact, this Virudhunagar District Pediatric Forum is well within the IAP Madurai limits, and this forum was created a few years back for better interaction of the pediatricians of Virudhunagar district. And in fact, we used to conduct regular scientific meetings once in 2 months, and so far we have very distinguished academicians as our visiting guests. Likewise, even in this tough period of lockdown, we are routinely conducting our once in 2 months academic program, and last academic program was conducted 2 months before, in which Dr. S. Ramesh Babu, HOD, pediatric urologist from Ramachandra Medical College, spoke on an approach to wet child. Virudhunagar district pediatricians are having continuous quest for knowledge, and it is very, you'll be surprised to know that for the regularly academic meetings, they used to come in large numbers. A guarantee of 30 members will definitely come and attend the meetings. And for today's meeting, and we have the distinguished guest, Dr. Elanthirayan sir, pediatric surgeon from Cuddalore. And in fact, Dr. Elanthirayan sir was supposed to come to Sivagasi when I was the president of IAP Madurai a few years back, and he invited him. Somehow he couldn't come. And another missed opportunity is I invited him to be guest speaker for the now abandoned Sangam Pedikan at Takadi because of the corona. And of course, he concurred to come, but we couldn't able to conduct the program because of the corona pandemic. So in order not to miss Elanthirayan sir's deliberations, I invited him for this month scientific meeting. He readily agreed, and we are very, very happy and privileged to have Elanthirayan sir here. Needless to say, pediatric medicine and pediatric surgery are inseparable specialties, and usually they go hand in hand. Again, I need not emphasize, many medical conditions will mimic a surgical picture, and a surgical condition may present with a medical problem. So now, truly, it is we are very, very privileged to have a wonderful pediatric surgeons here in Virudhunagar district. And the one who is in the screen is Dr. Arun Kumar, a gold medalist when he finished his MCh pediatric surgery at the Institute of Childhood. With his vast knowledge and the enthusiasm, we are conducting so many pediatric surgeries here, even in immediate neonatal period, like congenital diaphragmatic hernia, tracheoesophageal fistula, all sort of complicated surgeries he is doing. Thanks to his expertise, now we are breathing a heave of sigh of relief, because most interception cases, now they are getting conservative management because of his expertise. And needless to say about Elanthirayan sir, he is a well-known figure in the both academic as well as non-academic circles. And I am amazed by his non-academic skills, ranging from yoga to various art and conserving the nature activities. And I request Dr. Arun Kumar to give a foreword about this topic and introduce the today's guest speaker, Elanthirayan sir, and then Elanthirayan sir will take over. Over to Dr. Arun Kumar, please.
Yes, sir. So, thank you, sir. Thank you very much, sir. Good evening, one and all. So, I am Dr. J. Arun Kumar, pediatric surgeon, practicing at present now in and around Sivagasi. And I am running a 20-bed hospital called AJ Hospital, which is a specialty for pediatric surgery at Sivagasi. And I am supporting all the in and around pediatricians nearby town with my experience at ICH. So thank you, Venkat sir, for giving me this opportunity to introduce today's speaker, Dr. Elanthirayan sir. So from my student period, I have been heard of Dr. Elanthirayan sir in various meetings and in various speeches given by him, and in particular to his extra academical work, which sir is very famous for. Good evening, sir. Welcome, sir. Sir, basically, Dr. Elanthirayan sir is practicing at Cuddalore, He is running his own surgical unit with the name of Child Surgical Clinic at Cuddalore, and he is visiting consultant at Sri Krishna Hospital, Cuddalore. So basically, Sir underwent his MBBS from the year 1991 to 1997 in Madras Medical College, and Sir completed his MS General Surgery from 1999 to 2002 in Stanley Medical College, and Sir pursued his MRCS Edinburgh in the year of 2002, and then Sir pursued his MCH Pediatric Surgery from 2003 to 2006 at the Institute of Child Death, Egmore, Chennai. And Sir also completed his diploma in laparoscopic surgery in the year of 2003. And Sir has done many presentations and papers in various South Indian, our Tamil Nadu Pediatric Surgical chapters and Indian Association of Pediatric Surgery chapters in various topics. And some among this is liver tumors and neuroblastomas and TMJ ankylosis in children and ocular teratomas. And Sir has given many guest lectures regarding fetal anomalies and yoga for younger doctors in State IAPS conference in Trichy, and many guest lectures regarding A to Z of pediatric surgery at Lakshmi Narayana Medical College in the year of 2009. And Sir has given recent updates of pediatric surgery at Pondicherry Pediatric Forum in the year of 2015. And still, Sir has done many publications regarding pediatric surgery for practitioners and pediatric surgery tips and thoughts. And Sir has released a booklet regarding the scientific aspects of yoga in 2009. And these are some of the publications of Dr. Elanthirayan Sir. And Sir is also owing many official posts in the region of Cuddalore. And Sir has been the secretary for East Coast Pediatric Surgeons Club from the year of 2007 to 2010. And Sir has been the district coordinator for the IMA RNTCP program, which was a national project between 2008 to 2012. And Sir has been the chairman of the Crisis Management Committee in the IMA Cuddalore from the year of 2016 to 2018. And Sir has received many awards, like he has got the Best Doctors Award in the year of 2016 from Tamil Nadu State IMA. And he has gotten a State President's Appreciation Award for running the Needhi project in the year of 2018. And Sir has got IMA Appreciation Award from our Tamil Nadu Governor, Mr. Rosaya, for being participating in the Disaster Relief Fund during the Uttarakhand floods in the year of 2013. And Sir has got the Young Surgeons Pediatric Surgeon Traveling Fellowship for the year of 2018 by the Indian Association of Pediatric Surgeons. And in addition to these all academic and non-academic achievements, Sir has been shown his excellence in various other fields like yoga. And Sir has been a practitioner of yoga for the past 15 years and a qualified yoga instructor for an yoga center called Satyananda Yoga Center. It is in Chennai. And Sir is a passionate bird watcher and a wildlife enthusiast for the past 10 years. And he has a travel record for that, for visiting various sanctuaries and reserve forests in and around Western Ghats. And at last, Sir is also a good drawing and a painting skillist. He has displayed many various paintings and drawings in various district level art exhibitions. And he is also running a freestyle dance academy called Rack Dance Academy 2, which is a freestyle dance. So this much of extracurricular activities Sir is being interested also. So I welcome Dr. Elanthirayan Sir very much for giving this very important topic, which is secrets of pediatric surgery, which is very much important for the pediatricians as well as the general practitioners who are doing GPs, which will be very helpful in case of managing pediatric emergencies, which we come across day to day of our practices. So even though if pediatric surgeons are available, the initial management should be known for each and every general practitioners and pediatricians regarding any pediatric surgery emergencies coming in terms of chest or abdomen or in oral emergencies. So thank you very much, sir, for giving this topic. I hand over the mic to you to continue the topic, sir. Thank you, sir. Thank you, sir.
Thank you, sir.
Thank you, sir.
So it is my great pleasure to meet you all. I thank the Virudhunagar Pediatric Forum for giving me this opportunity, mainly at this Corona time, to just interact with people, to meet people and our fellow practitioners and colleagues. Gives a great joy to me. And at the same time, my heart really pounds with a lot of concern for our profession, our professionals, because we know we are in a real tough situation. So at this moment, when we are all here, I pray Almighty to give all our colleagues and friends the support to stand in front as real warriors between the community and the corona, and in the process save our community and save ourselves, keep ourselves safe. So my hearty prayers and wishes for you all to be safe, do practice safe, and be real warriors. So with those words, I thought we'll go to the proper topic. So we have, after the discussion with Venkat sir, we thought we'll name it as Secrets of Pediatric Surgery. Because this being a virtual meet, we don't know whether we'll be having a really interested audience. So we thought we'll induce some curiosity into the audience. So that's the reason we put it as secrets. There is nothing secret about this. These are all open secrets, and you'll know as we go. The presentation's focus is going to be on these things, the slide. See, a good surgeon is one who knows how to operate. A better surgeon is one who knows when to operate. The best surgeon is one who knows when not to operate. This is the old saying. So when there is going to be a complication and there is no need to operate, then actually we don't have to operate. That leads to a lot of complications. So this presentation's focus is going to be on practitioners, good practitioners. See, good practitioners know when to refer, but the best practitioners know when not to refer. So that is going to be the focus of this presentation. We all know there are obvious pediatric surgical conditions which needs a surgeon's intervention. So my focus is not going to be on that side. It's going to be on the other side of the coin, where there are a lot of conditions which don't actually need a surgical intervention, which need proper knowledge, guidance, and reassurance to the patient as well as to the self, to the doctor, that he or she can manage it. So those are the conditions, the non-surgical conditions, I would put it that way, because they might appear to be surgical conditions which are generally referred to a pediatric surgeon, but they are conditions which, if you know the real reason and the pathology, things which you can handle, so that it avoids a lot of confusion, anxiety, and discomfort for the patient. So I would like to empower you all into that Superman mode, which is seen on the screen. I would like you all to be best practitioners at the end of this session. So what to expect in this presentation? Of course, any scientific presentation should have a lot of science that is going to be there. And then there's going to be a lot of science ways, how to examine, how to elicit, and what to arrive at. And of course, there's one more science, our own experience, my own, that is a signature, that is a thumb impression, my own experience, which I would like to share with you as a pediatric surgeon, as a surgeon, and things which we see in our OP, which we share. So all this put together is going to be the sum up of this presentation. And to give a bird's eye view of this presentation, as I told you, this is going to be main focus is going to be on common things which we see in OP, in a pediatric OP, be it a pediatrician or a non-pediatrician. Common issues like abdomen pain, constipation, which come to a pediatric OP, which can be very well managed in a pediatric setup of pediatric OP, which might not actually need referral or further surgical intervention. So as the doctor who gave me the introduction told about me that I'm an ornithologist and wildlife enthusiast. That is always in my blood, and that's my passion. So my slides will contain a few of these wildlife issues or pictures. So the bird's eye view is going to be that. And if you notice, this is an owl picture. The owl has one pupil dilated and the other pupil narrow. If you notice, the narrow pupil is on the light containing side and the wider pupil is on the darker side. This is a very unique quality for owls. Humans cannot do that. We cannot regulate one pupil. owls can regulate each pupil individually. So we should be thankful for nature, because owls sometimes they have both eyes on in the front. So sometimes one eye is exposed to light, other is not exposed to light. So that helps them differentiate or pick up their prey better in night. So that's about the owl's eye view. So we are going to look at these topics. One is about skin. Skin, I mean, a lot of infections, abscesses, burns, other things. Abdomen pain is a common topic. Then the main points, I'll come to that later. And then there's going to be about lumps and bumps, small, simple swellings. Then there is going to be something about entry and exit issues. Entry is what I mean by swallowing, upper GI. Exit issues is constipation. And then the last thing is going to be about timing of surgeries, when to operate in pediatric surgical conditions. So coming to skin, we are going to deal with a lot of injuries, how to deal with them, which can be dealt very well in a OP setup by any practitioner. And then second thing is about going to be infections, basically abscesses and scalds or burns, because burns are very uncommon in pediatrics. Almost 90% of burn injuries are actually scalds. So I've put a snake there for skin, because we know snakes are actually the animals which keep on removing their skin. So it happens monthly. No creature in the world actually sheds off its skin so frequently as a snake. So that is one example of a beautiful skin renewal. And for a small information, people might know, skin is the largest organ in our body. Actually, liver is the biggest viscera, but if you take as an organ, skin is the largest organ in any human body. So going on to the injuries proper, as I told you, skin is the largest viscera. Any breach in that viscera can cause a weak point. So any injury needs cover for three reasons. One is for hemostasis, two is to avoid infection, organisms going in, three is for better osmosis. All three reasons why we do a management of skin, either with a suture or any technique for that matter. So what are the options when we have an injury for a child in a OP? Of course, we know the time-tested method of suturing, and we have got beautiful suture materials available. So this is a standard technique. Suturing is, if you know suturing and if there is an indication for suturing, best go ahead. And the other option on the skin is stapling, staplers. Nowadays, we have skin staplers. They're exactly like the stationary staplers. They work that way, they look that way, and they have a better edge over the suturing, because they produce less skin marks. Actually, sutures, we sometimes tend to tie a little tight and they produce skin marks, whereas the staples don't produce, or rather, they produce less. So that way, staples are preferred over sutures in some sites where the skin is really loose or just coming up. And these are the standard methods. And what I would stress further, other option is steri-strips. Steri-strips are adhesive strips. If you notice here, this is a post-operative wound, a laparoscopy wound, where I've removed the sutures, and there are suture marks, if you notice. This is what I was talking about. The suture marks are definitely going to be like 2 dots on either side of the incision. So the focus is going to be to avoid this. How to avoid this? That I'll come in the next slide. So next to the suturing and the stapling, what we have is the steri-strips. Steri-strips are very good options. They can just pull the skin together as shown in the screen. I put it across so that they pull the skin together and get adherent. So these are three options, but the best one, I would say, the one which I use nowadays commonly for the past 5 years or 6 years, is tissue glue. It is nothing but a small chemical called N-butyl cyanoacrylate. This is coming in various trade names, Dermabond and things like that. What it does is, it just like magic, it sticks the two edges of the skin. So this is something which is amazing, works well, pain-free, and allays a lot of anxiety, because once you have a needle, suture, all those things, the child gets anxious, the parent gets anxious. This is a totally painless, we don't have to apply local anesthesia. It's a very painless method and very neat method for skin approximation. If you want to look at it, see, that is an injury that is immediately after application. So you see, obviously the skin, baby is crying, that's because of fear. But once you apply it, you see that just one single line, and there's no suture mark, and it's perfectly fine. The edges are approximated. for what appears to be actually a gaping wound. So this is something which works like magic. And going back to the slide, I mentioned it is cyanoacrylate. Here is what I like to mention as my thumb side, which I mentioned as the third side, right? Cyanoacrylate, if you notice, is a chemical which is exactly the same what we use in a Fevikwik. You know Fevikwik, right? It's a 5 rupee adhesive which is available over the counter for a lot of stationery shops. And if you look at it, you will find it is exactly the same, the cyanoacrylate. Of course, this is of course medical. I might not be authenticated to say we can use it, but it happened in Corona. Because 2 weeks back, my cousin sister called up from Chennai and she said her child, 3 years old, had an injury in the eyebrow. I asked her to get this tissue, which was not available, and there was no doctor available because it was a lockdown time at Chennai. So I just told her if she has that Fevikwik. I asked her, and she said fine. So I just told her the application technique, and believe me, she applied it and it worked. And I know it works because I've been contemplating on this of using cyanoacrylate. Of course, this was one opportunity, Corona, where my own cousin, I could try it upon. I won't advise you all to do that because it needs precision. But when such situations occur, sometimes it induces a lot of creativity or crisis management. So that was one off-bit experience. But generally, I would suggest you better use N-butyl cyanoacrylate tissue glue, which is quite available. If you can stock it in your clinic, there are methods to use it. If that is specifically someone wanting to know it, you can very well contact me in my number. I can actually show you a video, or I can actually demonstrate to you, or you can talk to you. So that is one thing which works like magic. I would suggest this for any skin suturing. We use it, of course, for surgical wounds as well. And coming to injuries, one exclusive area which we have to talk about is mucosal injuries. What we have been discussing about is skin injuries. Mucosal injuries are unique in that generally mucosal injuries occur over the oral cavity. Of course, they can occur in the genitals as well. But generally, mucosal injuries in oral cavities are due to children playing with pen or pencil in their mouth, or sometimes with the brush, they trip and fall over. The pencil or pen goes. You can notice in that there is a flap hanging because that pen or pencil with the child had has gone and stuck there. Sometimes the small rods or sticks which they have, they just poken. So this is mechanism of injury in mucosal injuries. Here, as I told you, there are 3 issues. One is cosmesis, second is infection, and third is hemostasis. In mucosal injuries, cosmesis is not a problem because it is going to be inside. And infection generally is not a problem because oral cavities have very good antibacterial saliva. So infections in oral cavity wounds is very uncommon. And so those 2 issues are almost neutralized. Of course, bleeding is a very serious issue in these oral cavity injuries because we have seen children with mucosal injuries in the oral cavity bleeding a lot, swallowing a lot of blood. Sometimes we give general anesthesia and then they swallow out blood going for aspiration. So bleeding is a real risk in mucosal injury. So the indication for handling a mucosal injury will be bleeding, and 2 is a hanging flap like this. If you notice in this film, there's a flap of tissue hanging. So this cannot go and stick there. So this has to be approximated. So this might need general anesthesia. Generally, oral mucosal injuries need general anesthesia. This is one injury which can be very well managed at OP. If you notice, this is a mucosal injury in the lip, but there is not much of bleeding. So 2 things. If there is a bleeding or a hanging flap, we are going to use it. But if this is an injury, this is going to heal well without a scar, and there is not going to be infection. So we can very well manage in the OP. So this is one typical example of what should not be managed in OP. And this lip injury is something which can very well be managed in OP. Just observation. Inform the parent that if there is a bleeding, please do come back. Otherwise, you can very well manage in the OP. And tongue injuries are part of the oral cavity injuries. I've given pictures for illustration. This is a tongue injury, and this is a tongue injury, and this is a tongue injury. The difference is these 2 tongue injuries, the injury is away from the edge. So there is no actually a hanging flap. This is quite deep. There is gaping, but still there is no hanging flap. Whereas here, if you see, this is the edge of the tongue, the outline. This is an injury in the edge. So there is a hanging flap. This cannot get approximated at all. Whereas these 2 will get approximated very well and they heal well without scars. So if there is no bleeding in such type of injuries, these are indications to wait and watch. So this is the area I would like to focus Because for you, I would like to reassure that these injuries won't need any intervention, no suturing needed. Because if you are going to do a suturing for this, this will need a general anesthesia, and there is no indication if there is no bleeding. So if there is no bleeding, the mucosal injuries, especially the tongue injuries away from the edges, can be weighted upon. Whereas these hanging flaps, this is a pictorial depiction. These hanging flaps need approximation, and these are the ones which you have to refer to a surgeon. So notice, away from the edge, you can manage. On the edge, that definitely refer. Then the third category of injury, of course, is burns. It is also an injury. Burns is nothing different from an injury, only that it is a thermal injury. And as I already told you, burns in children are literally scalds. Very rarely we get dry heat affecting children. Mostly it is some sort of fluid pouring over milk or sambar or tea or hot water, whatever. So they are almost always scalds. So in scalds, we'll just on an overview, first degree, second degree, and third degree. So what is this? First degree, second degree, and third degree. So first degree where there is only epidermal involvement. Second degree where there is epidermal plus part of dermis, and third degree is whole of the dermis and sometimes below the dermis. So basically we are talking about degrees and areas. These are the how much is the surface area affected, what is the degree of the burns. These two are going to determine whether they are going to treat as a OP, whether they are going to refer them to a surgeon or a plastic surgeon for further management. So the burn injuries, or rather scald injuries, which are suitable for OP management are first and second degree. As I mentioned, they involve the epidermis and part of the dermis. They have not full thickness of the dermis. And if the burn surface area is less than 10%, then we can manage them in the OP. And if face and genitals are not involved, we can definitely manage them in the OP. Because when face is involved, there is a risk of upper airway tract obstruction, and when genitals are involved, there is a high risk of septicemia, infections, all those things. So these are the ones. So basically, scalds, and first and second degree scalds involving the trunk,
please message your
can be treated as OP. Others all need to be referred to a surgeon. So how do you differentiate whether it's a first or a second degree? I have told about epidermis, dermis. How to practically or clinically differentiate a first, second, and a third degree scalds. So if you notice, first degree scalds involve only the epidermis. So the nerves and the vessels are intact. In the second degree, it involves a bit of the dermis. Here, the whole of the dermis is gone. So the nerves are gone. So if you notice, in clinically, epidermis will have just the first degree will have just redness. Second degree will have blisters, and third degree will be just white. So this is a very simple and practical way to assess. If there is just redness and pain, because these are nerves intact, these two will have pain because the nerves are intact. Painful red or painful with blister means first and second degree. And if there is no pain, white, definitely third degree. Third degree, there is no way you can treat it OP. So most of them, 80% of scalds in children fall into first and second degree. And if they don't involve the face, the genitals, and if they don't involve large areas of trunk, you are perfectly fine. You can manage them in your OP. So what are the principles of management? Number one is pain relief, because contrary to common belief, a lot of people focus on antibiotics. The role of antibiotics in a scalds injury is very less. Pain relief takes precedence. Second thing is whether we need to do a dressing or not. This we'll have to decide based on individual things. And third, role of antibiotics is limited and specific. I'll tell you about that. So number one, analgesia is top priority. Use ibuprofen, use sedatives. We have a lot of oral sedatives. I would suggest, unless the child is falling into a non-OP category, if you're going to treat it as OP, there is no need for IV fluids. There is no need for antibiotics even. So the dressing, I would suggest you can use it on day 1 or probably day 2. The role of dressing here in scalds in children is, one, it might avoid it might be a barrier against the airflow, because when there is a current of air flowing over a scalded area, it might induce those nerves and create some pain. So that is one reason. So you give a cover to avoid. Again, it is for pain relief. It is not for infection, because pain relief is one which can be provided by dressing. So first 1 or 2 days you can do a dressing. Other thing is, it allays a lot of anxiety. When it is covered, child is safe, child feels safe, and the parents feel safe. So day 1 and day 2, I would suggest dressings from day 3, leave it open, and dressings are not great magical. You just have to have two things in focus. One is it should be a non-adhesive dressing. You have all these soap tools and things like that, which act as a barrier between the open skin and the cotton or gauze, whatever you use. So there should be a non-adhesive layer between the exposed skin, the scalded skin, and the dressing material which you use. And the dressing material which we use should be absorbent. That is something like a pad, protein pad, which just has it on its surface. So whatever fluid which oozes out, it just collects. So that this is the quality of a dressing material, which is nothing but the routine dressings is available. The non-adhesive component you'll have to add in all those dressings. And antibiotics, role of antibiotics in burns or any scalds, the antibiotics are needed when there is a systemic infection. There is no need for systemic oral or IV antibiotics for first and second degree scalds, because what happens in when in a sepsis, when a child goes for sepsis, is there is transmigration of bacteria mainly from the gut. It is not just skin barrier is lost and you get organisms going across. It is because mainly from the gut. When it is third degree, then we have a lot of organisms going through the skin. So first and second degree burns, the role of antibiotics, systemic antibiotics, I mean, is limited. Of course, you can use local antibiotics, topical antibiotics, and even in topical antibiotics, the general habit is to use a lot of silver. So silver is something which is very powerful as an antibiotic locally, but it has a scarring tendency. So what I would suggest is, in first degree and second degree, again we'll go to the routine mupirocin and neomycin, which we use for any skin infection, because they have very less scarring tendency. So these are the ideal local topical antibiotics. Silver is stored or is saved for the grade 3 or third degree scalds. So for first and second degree scalds in OP setup, pain relief is number one. Systemic antibiotics, I would suggest not necessary. Topical antibiotics, use the routine mupirocin, neomycin. Focus on the non-adhesive component of the dressing for day 1 and day 2. From day 3, leave it open. This is perfectly fine. You can manage scalds very well in your OP. And coming on to the second component of skin infections, abscesses are commonest, especially in summers. So abscesses, we have done extensive study in abscesses in children. For the past 10 years, I am lucky to say I have a very good microbiologist friend of mine. She does a lot of work on this. And what we have observed is, and what matches with the literature is, 95% of these abscesses show Staph aureus, out of which 40% are MRSA, methicillin resistant Staphylococcus aureus. And the second point is something which is very exclusive of our study here in Cuddalore. The drug of choice for Staph aureus is not amoxiclav. We have been using a lot of amoxiclav, and what we find is, in our past 10 years experience, cloxacillin is perfectly fine, but amoxiclav, we find it resistant for almost all cases of Staphylococcus aureus over the past 10 years in these abscesses. This is something which has to be taken into our mind, taken into consideration, because cloxacillin works fine, and we have been doing this for the past 10 years, and amoxiclav has found to be, the organs have found to be resistant to amoxiclav. And we, of course, have this sect of MRSA, with this 40%. They come as non-healing wounds. And when it comes as MRSA, we'll have to do a specific sensitivity. And we have usually these 4 choices coming up: erythromycin, cotrimoxazole, clindamycin, and linezolid. I mentioned linezolid in red because it's a general tendency to choose the best or the top antibiotic when we have a sensitivity pattern. I would suggest against this. Go for a erythromycin, go for a cotrimoxazole. These are basic drugs. We need to store or save linezolid for bigger infections. So for just an abscess which have already been drained, probably you'll do better off with an erythromycin or cotrimoxazole for a week for MRSA. If there is something non-healing, you want to go at second line, then use linezolid. So don't use linezolid as an oral drug for first line in MRSA. And talking about injection site abscesses, the first point I would like to share with you is, I kindly request you all, kindly don't write the diagnosis as injection site abscesses, injection abscesses, because there is no such diagnosis. For everything we get cheek abscess, arm abscess, thigh abscess. What is an injection abscess? It gives a negative impression. It gives something, puts something into the mind of the mother that the injection was wrong. So it leads to a lot of medical legal issues. We have seen that practically. So never ever mention something as injection site abscess. You as usually refer it as thigh abscess or refer it as gluteal abscess. That is perfectly fine. Don't take this injection abscess from your mind. So injection abscesses are exclusive in that basically you have to understand the mechanism. What happens is when we put an injection, the needles drive in the organism from the top of the skin. Even though we wipe it with some antiseptic, there are few organisms which might be left over, and the injection takes it down into the muscle, and it can cause an abscess. Other thing is when we put when we give an injection, the injection drug might get deposited into the subcutaneous fat. It might create an hematoma there, and that hematoma gets or colonized by the organisms, and that can lead to a lot of injection site abscesses. So these are the two proposed mechanisms for injection site abscesses. There is nothing greatly wrong with the doctor or the drug. Most often it is these mechanisms. Even though we clean it perfectly, sometimes they do produce these things. Sometimes the spirit which we use, sometimes overdoing of spirit, can also produce some sort of allergies and reactions, can lead to abscesses. And the profile of microorganisms, what we see is 50% of these pus is sterile. They don't produce any growth. And 40% is staph. 3 to 5% is the rapidly growing mycobacteria. This is something I would like to bring to your attention. So the rapidly growing mycobacteria is something which we get in post-surgical wounds as well as in these injection abscesses, which are very difficult to treat. If we put the regular drugs, they don't get cured. So the drugs of choice, what we have seen from the sensitivity pattern, are erythromycin, cotrimoxazole. Again, linezolid comes here. And luckily, the post-surgical infections are more severe, and these injection abscesses are less severe. And what we do is use two drugs, erythromycin plus cotrimoxazole. We use this for 2 weeks, and for further 8 weeks, we use single drug. So combination therapy for first 2 weeks, and for the next 8 weeks, a single drug therapy. This is what we follow, and generally they respond very well. And this linezolid again is saved for the next level. We don't usually do it for the first level of when they are non-healing only, we go to the linezolid because we want to save a higher antibiotic for the next level. So rapidly growing mycobacteria, use double drug therapy, 2 drugs for 2 weeks, and then for next 8 weeks, so both the drugs. To sum up all these things, injuries, first we have to assess if there is a bleeding, if there is a cosmesis issue, if there is an infection, then you decide. Tissue glue is excellent for skin cover. I would recommend you all to get used to it. Oral cavity injuries, if there are no hanging flaps, if there is no bleeding, you can very well manage it conservatively. And for first and second degree scalds, pain relief takes precedence. Antiseptic local and antibiotics are fine, and dressings mainly have to be non-adhesive. For abscesses, cloxacillin is the drug of choice. Of course, cloxacillin may not be available as an isolated drug. What I use is ampicillin plus cloxacillin combination, which is available as a syrup and tablet. And for MRSA, cotrimoxazole and erythromycin combination therapy works very well. And coming on to abdomen pain, we are going to discuss about 4 exclusive conditions, because this is not going to be an extensive topic on abdomen pain. We have a lot of issues. These are the issues which are usually concerning for a practitioner, because these are issues we get in an ultrasound. Nowadays, abdomen pain, mainly apart from the 5 fingers which we use, the 6th finger is ultrasound probe, because ultrasound has evolved a lot. And when we give a lot of inputs to the sonologists come out with amazing diagnosis, and the profile itself has changed in abdomen pain in children. And we find a lot of new things like transient intussusception and recurrent ovarian torsions. This is mainly because of the evolution of the ultrasound. So we use ultrasound literally as our 6th finger in abdomen pain. And these are the things which we are going to discuss. And before going on to the abdomen pain, I put a picture of the cow there. I'm not sure how many of you know that a cow has 4 stomachs actually. The first stomach is something which it just puts in all the grass. The grass is first grossly digested, then it comes back, then it chews. That's what we see, right? It keeps on chews, and then pushes it back to the second stomach, where second level of digestion takes place, and third level again takes place, and finally swallows to the 4th stomach, which is literally equivalent to the routine stomach which we have. So that is one interesting fact I would like to share with you. As I told you, the 6th finger is ultrasound probe. We need to be in communication with the radiologist, because sometimes we see requests like abdomen pain for USG. Please don't do that. I would request you to kindly put in your inputs. Like is there a vomiting? Is there something else? What is in your mind? This I learned from my teachers at ICH Egmore. Commit whatever you think about that might be wrong, that might be your suspicion. Put that into the mind of the sonologist. That might be a very important lead or clue to that. So kindly put your findings, even if it's a small slip, and then if you want, call up, discuss. So this is something which is very useful. I find it very practical and useful while sending a child for especially a radiological investigation. So we are concerned generally when the ultrasound, this is a common scenario. Ultrasound, the child comes with severe abdominal pain, very anxious, sometimes with vomiting, and the whole family is very concerned. Ultrasound comes as normal. This is something quite common in pediatric surgical practice. So we are puzzled what to do, what to proceed. Of course, one thing which I find is most of these are food allergies due to the snacks, packed items, which produce sort of food allergy, sort of reaction, and this pain is quite severe. Child doesn't tolerate. It comes as episodes, and it keeps coming for 2 weeks, 4 weeks, or even longer. So I just tell them, if a scan comes as normal, you just have to be reassured it is not a major problem. There might be small problems. You just treat symptomatically with antispasmodics. Reassure them, talk to them, tell them this scan is normal, fine, there might not be anything serious. So you'll have to reassure them. Otherwise, what happens is you tell it it's normal, there is pain, this is normal, you just prescribe. What happens is they just go back to another doctor, or they just take another scan. They keep thinking about further scopy, CT abdomen, other things. Once an ultrasound abdomen comes as normal, and clinically the child is okay, there's no point for any serious disease. Reassure them, but keep them on follow up. I would say this, insist. Ask them to come after a day or two. Ask them to come after a week. Tell them if these warning signs like vomiting, bleeding, PR, things like that occur, please do come back. So with that word of caution, you reassure them, talk to the parent. So if it is a normal ultrasound abdomen, actually I would say the parents are worried. Caesar, there's a pain. How can it be normal? You have to reassure them. And then the two exclusive conditions which we are going to discuss. Mesenteric lymphadenitis is something which often creates a lot of anxiety for the doctor as well as the parent, because they say there is a cutty inside, and how big is that, and what is that? People actually, parents assume it is a tumor, because once you say it's a cutty, then they assume it's a tumor. So what happens is these are specific indications to signify a lymphadenopathy. If it is a node, if there is a single node, even if it is more than 8 mm in the shortest axis. If you notice, this is a node, this is the long axis of the node, because nodes are oval structures. This is the long axis, this is the short axis. In the short axis itself, it should be 8 mm or more. Or so, which means the minimum measurement given for a node should be 8 mm, and the other should be more than that. Obviously, the long axis is going to be more than that. So if you see a node which says 10 by 5 or 10 by 6, then it is insignificant. Whereas if you see a node 8 by 9, it is significant. The shortest axis is 8 or more, then you take it as significant. So that is one size criteria. So shortest axis more than 8, then there is a cluster of nodes. That is again significant, more than one node, as shown in this picture. And then the loss of architecture of nodes. Again, the nodes architecture is lost, means definitely that is a significant indicator of serious disease. And if there is perinodal inflammation, these are all indicators of significant lymphadenopathy. But what we see in practice, very rarely, I would say once in a year, I would say about 4 or 5 children with a size more than 8 mm. That's all. And cluster of nodes, again, the whole thing, if you put mesenteric lymphadenitis, significant mesenteric lymphadenitis in the years of practice, in 1 year of practice, I would see 4 or 5 children, which is very less. So in short, you'll have to look at these 4 features. If they are not there, you have to reassure them it is not serious. So knowing about mesenteric lymphadenitis, it could be infective. Infections can be predominantly involving the gut. Mostly often we find it is a viral infection, not bacterial. So the role of antibiotics again here is limited. I suggest don't go in for antibiotics for a mesenteric adenitis. Of course, we have inflammatory conditions like Crohn's or malignancies, which are quite rare. If these are there, then obviously they get larger size nodes or nodes with a loss of architecture. So don't worry about these things. Infection is something which comes to our mind when we think of when we get a report as a node. Kindly resist the temptation to put in an antibiotic. The best drug would be paracetamol, not even an antispasmodic, because it is often very tempting to write an antispasmodic for an abdomen pain, but here the pain is because of mesenteric lymphadenitis. If so, an anti-inflammatory will work better than an antispasmodic. So this is the message I wanted to get across. The other thing, which often again creates some sort of whether to refer to a surgeon, what to do, how to follow up, is gallbladder calculate, which we see often nowadays. One reason I attribute is probably the use of ceftriaxone in large numbers. I'm not very sure. So when we have a report of a gallbladder calculate, first thing we have to ensure is it is not a sludge, because gallbladder sludge can be very similar to a gallbladder calculate. How to look at that? We can very well, as I told you, the simplest method is ask the sonologist, call up whether it is a calculate, are you sure, or is it a sludge? Here is one method. I've put a red arrow. This is the calculus, and there is a shadow here. This is called post-acoustic shadowing. Beyond the calculus, there are small shadows. If you notice, linear shadows, shadows of this calculus. So that is called post-acoustic shadowing. This is there only in a gallbladder calculate, not in a sludge. So if you have a shadowing, you can be sure it is a calculus, not just a sludge. So once you know there is a calculate, then we'll have to ask the sonologist what is the size of the calculate and what are the numbers of stones. So once we have this, this is going to be the baseline ultrasound. Unless there are biliary symptoms like obvious rigors, fever, jaundice, and upper abdomen pain, which is unbearable, we need not go in and do a cholecystectomy. So we look for other findings which are significant, like a pericholecystic fluid, gallbladder wall thickening, which all indicate inflammation of the gallbladder. If they are not there, just individual gallbladder stones, 1, 2, 3, whatever numbers, without any of these pericholecystic fluid or gallbladder thickening, we are just going to wait until that. There is no actual specific indication for cholecystectomy unless it is grossly symptomatic, especially with biliary symptoms. Here is one typical example. This was a scan taken. It shows 2 gallbladder calculi. 6 months later, the number has come down to 1. So each time you will have to document the size as well as the number. If there's a reduction in the size or the number, we are happy. If there is an increase in the size or number, we'll have to repeat the scan frequently, maybe monthly. Look for an increase in size or number. If that is progressing, then probably we'll have to go in for the surgical management. And a word on air calculus cholecystitis. As I mentioned, this is a clear picture. This is a calculus, and here you see a post-acoustic shadowing. This is a sludge. This is what is mentioned as a calculus cholecystitis. Here there's a lot of sludge. You don't see any post-acoustic shadowing. So this is very significant. A clear description or differentiation between a post-acoustic shadowing in a gallstone and a sludge showing no post-acoustic shadowing. So a calculus cholecystitis is a non-surgical condition. So you'll have to probably look for others, as I told, pericholecystic collection, gallbladder thickening, and they are all pointers for a systemic disease in children, typhoid, dengue, or leptospirosis. You might all be well aware of that. So a calculus cholecystitis, don't worry, it is not definitely a surgical illness. You'll have to deal it as medical illness. So the modern day musings out of ultrasound evolution, I would say, is we have a lot of children coming with colicky abdomen pain without any symptoms or with vomiting alone. There is no bleeding PR, no mass. But you see there is an ultrasound finding showing an intussusception. These are all transient intussusceptions. Here you see, this is a classical intussusception where the small bowel, terminal ileum, goes into the cecum and the large bowel. So this is typical site for ileocecal junction is a typical site for any classical intussusception. I'm not talking about this. Here you see, this is a small bowel where you see small bowel going into small bowel. The length of the intussusception is usually less than 2.5 and it is transient because it is seen in one scan. After an hour, if you repeat, it is not there. After an hour, it comes back. So this is a telescoping of bowel within bowel transiently. In such children, definitely admit them. You cannot send them home. Definitely admit them. Put them on antispasmodics. Give them pain relief. 1 or 2 days it remains and then it goes off. So this is something which you have to be aware of and put it into writing when you send a patient suspecting transient resuscitation, put it to a sonologist, they might be able to pick up. Another thing is recurrent ovarian torsion, which we are seeing nowadays. It is not classical ovarian torsion producing gangrene. This is torsion, detorsion, which typically mimics appendicitis. This again we are able to pick up because of the good sonology. We have a lot of hyperechogenic, enlarged hyperechogenic ovary with peripheral displaced follicles. And when we have such problems repeatedly occurring, we might go for a laparoscopic oophoropexy. And here I would like to insist, even in an acute torsion of the ovary with discoloration, where there is a doubtful viability, we don't do a removal of the ovary. We just do oophoropexy, even in acute torsion. In chronic recurrent torsion, definitely the treatment is oophoropexy. The reason I'm discussing here about this is you will have to be aware of these two things, transient intussusception and recurrent ovarian torsion, which are coming up nowadays. Of course, they are not common conditions, but these are things which you have to keep in the back of your mind when you send them for an ultrasound. You put them in writing and ask your sonologist to look for these two. To sum up the abdomen pain, mesenteric lymphadenitis, treatment of choice would be paracetamol. Asymptomatic gallbladder calculi, 6-monthly scan to assess two things. One is size and the numbers. Acalculous cholecystitis is a systemic disease, it's medical management. Transient intussusception, recurrent ovarian torsion, just keep it at the back of your minds. And of course, for any abdomen pain, give your inputs to the sonologist, it will be very valuable. And this is going to be about main points. Main points is something which which I usually use, or rather I hear people saying, because main point refers to genitals and the umbilicus. I get a lot of patients telling main point umbilicus, things like that. These are colloquial words which are used by patients. So we are going to discuss about umbilical issues and genital issues in main point. I put a dog's picture there because there might be a lot of people having dogs or pet lovers. Dog is one thing which amuses a lot of people in that it doesn't have an obvious umbilical cord. If you think about a cow, calf, whatever, any young has an umbilical cord, but dog doesn't have an umbilical cord. So it led to a lot of research, and they finally found, of course, dogs have placenta and umbilical cord, but of course, the mark is very less. So dogs actually don't have an obvious umbilicus. That is one interesting fact. So when it comes to umbilical discharge, there are three things which have to be kept in mind. Number one is granuloma. Number two is oncolytis. Third is the remnants, which can be patent pitulo-intestinal duct or an urachus. The first thing is something which I would like to focus upon because this is the commonest cause of umbilical discharge in infants. Granuloma is nothing but failure of epithelialization of the residual cord which has fallen down. It has to be epithelialized. That is a normal process. In some children, there is no epithelialization. So that results in a granuloma. If there is one thing which I would like to insist and share with you, kindly avoid local applications because this is something which is very commonly being done. Powders and ointments are being applied over the granuloma. There is no role for antibiotics or any local applications or powders for a granuloma. This is just failure to epithelialize. So you just have to wait and use cautery, which is chemical cautery. I'll explain to you. And granuloma, of course, is surprisingly less often diagnosed. The reason is we don't actually separate the edges, or rather, we don't look deep. I would suggest don't just examine the child with fingers. Use a small mosquito artery forceps. Once you separate the two folds of the umbilicus, you can definitely see granulomas in an umbilical discharge. That is very common diagnosis. Out of 10 children, I would say 7 to 8 have granulomas. Only thing we just fail to notice because we sometimes see outwardly there is a granuloma lying inside. So the identification is a trick. Once the identification is done, then we go to the copper sulfate, that is treatment part. So put in a proper examination light, a focus lamp, use a mosquito, and then just separate. So that's lights, mosquito, and action. So you'll definitely pick up a granuloma next time you see an umbilical discharge. And I mentioned about chemical cautery. What I use is a single application of copper sulfate crystals. We get copper sulfate crystals in with the goldsmiths, the jeweler shops. That is available. It is not actually available in the medical shop. You can get it in some of these shops. Other options are silver nitrate and rock salt. Rock salt is a very effective method, but I find copper sulfate preferable over rock salt because rock salt sometimes needs a lot of repetitive application, 3 times, 4 times. But rock salt is very safe. The patient is happy, mother is happy because it is a something which is available at home. Copper sulfate I find interesting and useful because single application it clears umbilical granuloma in 90% of cases. So the next question comes as how to apply, because copper sulfate is something which we fear as a chemical. Of course, it is a chemical cautery. So when properly used, it is very effective. So how much to apply? The first criteria is size. Here I mentioned, I've shown you a picture of a granuloma. The size is roughly, the thumb rule is apply the same size of copper sulfate as you see as the size of a granuloma. Just there has to be one rim of granuloma seen outside the copper sulfate. So the copper sulfate size of the crystal which you choose should fit over the granuloma, and there should be a small rim. You can see that lunar and solar eclipse where there will be a ring light. So that is a rough size. It may not be the same shape. That's a rough thumb rule. So the granuloma has to be slightly smaller than the copper sulfate has to be slightly smaller than the granuloma. That is one thing. So how long to keep? I keep it for 2 hours. I apply this, put a small plaster over that, ask the patient to wait in my clinic up to us, remove it, and then use a syringe, saline to flush whatever is residual there, and then wipe it and then send. That is one thing I do. But if the patient is educated, I ask them to do this at home. I give them a syringe. I ask them to remove that plaster after 2 hours, flush it with syringe, and then just leave it open. Single application is very effective, and this is something which can be very safely used if it is properly administered. Follow up, I ask them to come after 4 days just to see if it has fallen down. If it is still there, I again ask them to come after 4 days. If it is not falling after 2 weeks, I do a second application, which is quite uncommon. So omphalitis is again one second reason for discharge. Those going in for complications like cellulitis and first tracking along the umbilical vessels are very, very uncommon. Most often these omphalitis are superficial skin infections. You can be very sure you can treat them properly with antibacterials. Staph and streptococcal or the organisms, oral cefalexin and fluoxetine are going to be very effective. Sometimes what I do is after a week of these oral antibiotics, if it is not recovering or if it is not responding, I use topical cetoconazole antifungal along with the oral antibiotic. So this combination is quite effective. But first line, I use only oral cefalexin or fluoxetine. After a week, if it is continuing, then I use topical cetoconazole. Topical cetoconazole is to be used for 3 weeks. That can be used for a week or so, antibacterials. And the main point, of course, is actually the genitals. Lot of anxiety over small genitalia is something which we see in a pediatric OP. Parents come with children from 5 years to 15 years. They're anxious that the penis is small. And I would say 95% of times it is just a buried penis. It is not an abnormally pathological penis. If you notice in the second picture, there's a lot of excess pre-pubic fat deposition. This is something which we are finding in a lot of children. Obesity is a very common issue. So when there is excess of pre-pubic fat, what happens is, see, I've just pushed that pre-pubic fat and his phallus looks fine. So you just have to do this in front of the parents, reassure them it is just that excess pre-pubic fat. If they need some more documentation, put in a scale. This is the rough or rather measurement which you can do in a OP. Stretched phallus length for 2-year-olds, if it is more than 2.5 centimeters, perfectly fine. The genital length is perfectly fine. For 5-year-olds, 3.5 centimeters, and for over 10-year-olds, anything 4 centimeter or okay, over is perfectly fine. So put in a scale, don't push it too hard, it might hurt them. Just if you notice the picture, I put in a scale, I've just lifted up the phallus and it is not stretched a lot. So I mean, it's not, I'm just pulling it out, pushing this, just holding it there. So if that is more than the above mentioned criteria, reassure them it is a normal penis. It is just that pre-pubic fat which is causing that appearance of a small phallus. So don't worry. This often we get in pre-pubertal age group. Once puberty occurs, then the fat deposition changes and the genitals start growing, and this is not a big issue in post-puberty issues, post-pubertal conditions. So other thing is retractile testis. Again, this is something which causes a lot of concern. Most often, undescended testes are very, very obvious. If you still have a doubt, you can just milk it down, bring it down to the scrotum. If you can see it there, both testes in the scrotum, show it to them. Retractile testis cause a lot of anxiety to parents. You just have to reassure them. If the testis, you are able to pull it down to the bottom of the scrotum, And by definition, it has to stay there. But actually, if you are able to bring it to the bottom of the scrotum itself, you can be rest assured it is going to be a retractile testis, not a undescended testis. And phimosis is something, an evergreen topic. I'm not going to talk a lot about it. One simple indication is these are all conditions which might need a circumcision. But my simple suggestion is, if you look at the phimosis in a child who's more than 1 year old, if there is something like a pinpointed opening which is not showing the meatus, then that is an indication for circumcision. Otherwise, gentle retraction will do. I would suggest this as at cleansing. This is a wrong method which I have shown. This is not something which should be done. You cannot put in an artery forceps and just open it, because that will produce ulcers like that, and the ulcers heal with a lot of fibrosis. So actually the fibrosis gets worsened. Initially it will look okay, but in 1 month you'll have a more severe sort of phimosis. So don't do this. Just ask them to retract. However tough you ask the mother to retract, she'll do it only gently. So that is what we need. Ask them to just push it gently, and topical applications. Lot of steroids are available. I use a 1% hydrocortisone. The role of steroid here is to soften the skin, and the mechanical stitch opens up the prepucial skin, and the topical application softens it. So a combination of mechanical stretching along with softening helps. This is okay for younger children, 1 year old, 2 year olds, but beyond one age, don't try to force, send them to a surgeon. And labial fusion, bulbal synechia, is something which creates a lot of anxiety. These children sometimes go to OGCNs, sometimes to pediatricians, general practitioners, and when they see there is no birth canal seen outside, that is a very big shock for the whole family. They think there is an absent vagina, absent uterus, the child is not going to reproduce, and whole cycle of panic sets in. I've seen children, lot of children being referred with a CT scan taken for presence of uterus or not. Sometimes even MRI is taken, and lot of hormonal analysis done for a small child with a labial fusion, assuming it is absent vagina, absent uterus. So kindly be aware of this situation. This is quite common diagnosis in children. Urinary tract infections or dysuria are quite rare. They can present with urinary tract infection or dysuria, but generally it is just appearance. The mother notices it while giving birth, and they panic and they come to you. You just have to do a simple procedure in the OP. Just up to 6 months of age, wait and watch. Local estrogen creams can be given to the mother, ask them to apply over it. Beyond 6 months, generally again you can use local estrogen creams, give a trial for 2 weeks, but generally they don't respond. So what I do is do a gentle release of synechia using a mosquito artery forceps. It is done in the OP. Use local applications, and then just gently do it. It opens out like magic. And what is more important here is local estrogen cream applications have to be done for next 6 months, and the child has to be followed for next 3 years, because the local estrogen is very useful to avoid refusions. They are very common. One thing is, ask them to use local estrogen applications daily for the first month, then alternate days for the second month, then once in a week for the next few months. So for first 6 months, ask them to use local applications. After 6 months, the mother has to just keep an observation. Every week she will have to check the baby while giving a bath. That's fine. So first 6 months, definitely it needs local estrogen applications. Here is where most of us fail. We just open up and send them back. They come back with a recurrence. So local estrogen creams help prevent recurrence. So about the main points, that there is the genitals and the umbilicus. Umbilical discharge, you just retract and see. That will help you a lot in diagnosing the umbilical granulomas, which are very common. They don't require antiseptic powders or ointments. Omphalitis, first line is antibacterials oral. Consider antifungals if they are not responding. Genitals, as I told you, are social emergencies. So show them the proper care. And we are going to discuss a few about lumps and bumps. I put a camel picture for that, for lumps and bumps. Camels, people have a misconception. They store a lot of water in their humps. That is not true. They have a lot of fat in their humps. That gives them the energy when they are starving while crossing deserts. They don't actually have water bags in the humps. So these are the topics which we are going to discuss in lumps and bumps. And nodes, especially neck nodes, Generally, children have neck nodes and scalp nodes. Scalp nodes are something which again creates a lot of anxiety in parents. They come with a lot of occipital, post-auricular nodes, which creates a lot of anxiety because anything which is a cutty, again, as I mentioned already, is it's a source of anxiety for the parents. And neck is very common. The significant size of a neck node is 2.5 centimeter or above. I would put it as 2 centimeters. Between 2 and 2.5, you'll have to be a bit careful. Anything less than 2, you're probably on the safe side. So when you have a neck node, how to assess it? First, see whether it is acute or chronic. Then the second question is whether it is localized or systemic. Are there any other groups involved? First, if it is an acute and a localized node, antibiotics for 7 to 10 days, because nodes actually need longer antibiotics than skin infections. So 10 days you might have to give. And if it is not responding, go for an FNAC. So if it is an acute localized thing, perfectly fine. Most of them will respond. You might not have a node which is completely regressing, but if it is showing size, reduction in size of the pain is gone, you can be perfectly happy, you can wait. But if it is not responding, there is no reduction in pain, the size is same, then go for an FNAC. Other thing is chronic nodes. Again, in chronic nodes, if it is a single node, I would suggest wait, reassure them, ask them to come back. Still, if you have doubt, then you go for an FNAC. In chronic, if it is a systemic involvement, we'll have to think about lymphoma and TB. So if it is chronic and systemic, definitely go for FNAC straight away. If it is acute and localized, put in a course of drugs. If it is responding favorably, wait before going in for an FNAC. Most often, these are non-specific lymphadenitis. And BCG adenitis again is one hot topic in pediatric. Once you have a BCG adenitis, the left axillar node, which is quite big often, it creates a lot of fear in any parent's mind. It is about the 3/2 size, usually what we get as BCG adenitis. But two questions we have to ask is, one, is there a pain? Is there skin involvement? As clinicians, assess if there is a pain or if there is skin involvement. By skin involvement, I mean the skin will be thin, it might have a sinus, it might have almost a puckering to the node. So if there is skin involvement and if there is pain, it means there is an inflammation. Not necessarily because of the BCG adenitis, there is some secondary infection probably causing the pain and the skin involvement. If it is there, what I would suggest is put in a course of antibiotics and anti-inflammatory, wait for 4-5 days. If the skin involvement goes off, you are happy, safe, leave it alone. BCG adenitis does not need any intervention unless there is a secondary infection, which is shown by the pain and the skin involvement. If there is skin involvement, if you have put a course of drugs 3-4 days, if it is not responding, most likely it is an abscess. I'm talking about these dicey conditions. If you obviously have a big abscess, stretched and shiny, go ahead and do an IND straight away. But if you have these dicey conditions where you're not able to access, put in drugs for 3-4 days, again cloxacillin and one of these anti-inflammatory drugs, wait for some time. If there is again continuing skin involvement, do an incision and drainage. Needle aspiration is not a good choice because many books or even literature suggest needle aspiration or non-dependent drainage. That is perfectly fine if it is going to be a tuberculosis. This is not actually tuberculosis. This is secondary infection in a BCG adenitis. So do a routine IND. It heals well, and there is no role for anti-tuberculous drugs in a BCG adenitis. There are a lot of discussions on that, but I don't use an anti-tuberculous drug for BCG adenitis. And coming into this lumps and bumps category, I've included this because antenatal ultrasounds are picking up a lot of hydronephrosis. This is again one situation which a practitioner faces very commonly. They come with an antenatal scan. A physician refers a mother with an antenatal scan showing a pelvic system dilatation, a hydronephrosis, whatever terms are being used, and the size is mentioned as 5 mm, 10 mm, whatever it is, and it creates a lot of concern in the minds of the parent as well as the physician. So, few things I would like to say. This is one of the commonest, I would say the most common antenatal anomaly picked up as a hydronephrosis, and about 1 to 2% of all pregnancies have this finding. So, is this significant? Of course, it is significant when we look at what is there in the measurement as well as what is the whether it is unilateral or bilateral and what is the Likert status. If a measurement shows more than 20 mm, then that is quite significant. Of course, that is very uncommon in an antenatal scan. So two things I would like you to focus is whether it is a unilateral hydronephrosis or a bilateral hydronephrosis. Because if it is unilateral, you are quite sure the other kidney is fine. So there is no role for antenatal intervention. You can be quite happy, allow the baby to deliver and then reassess. Whereas if it is a bilateral intervention, it might be a serious disease. So look whether it is unilateral or bilateral. If you have a bilateral situation, again go in and look at the liquor, because as you all might know, liquor is nothing but fetal urine. So if the liquor is not adequate, if it is less than the expected amount, then you know the both kidneys are not functioning well. If it is bilateral, if it is a single unilateral, definitely there is not an issue. So bilateral hydronephrosis with low liquor, that is a warning signal. Either it might be a severe disease, you might have to think in terms of termination if it is very severe, or any antenatal intervention. But this is very, very, very less than 5% of the entire hydronephrosis. So most of them, we have unilateral hydronephrosis with adequate liquor. This is a common scenario. So these are two things which you have to look at an antenatal scan. Again, our next question is the baby, whether we need to do a cesarean or a normal vaginal delivery. There is no specific indication for cesarean in the hydronephrosis. So the delivery is done as per obstetric indications. Next question is when to do an ultrasonogram. I would like to insist, never do an ultrasonogram for a newborn baby with an antenatal hydronephrosis unless there is oliguria or something like very serious bilateral disease, things like that. So because first 4 days there is a phase of physiological oliguria. So a scan done during that might not be giving the right picture. So you can probably schedule it at 1 week. This is a thumb rule. At 1 week, do an ultrasonogram, reassess the findings. So you can be very sure if the child is voiding within 24 hours, happy. There is no mass. If it is not bilateral disease, perfectly fine. So these are the three things which you have to keep in mind. If it is unilateral, you are happy. If the liquor is adequate, you are happy. And if the child voids after birth, you are happy. So you can do a scan at 1 week. And what to infer from the first week scan? If it is just hydronephrosis with a transpelvic diameter, that is the size of the pelvis of less than 20 mm, which is a very common, which is a common scenario which we see. And if there is no obvious urinary tract infection, you are on safe grounds. Just wait and watch with uroprophylaxis. Of course, you'll have to send these to a pediatric surgeon. So this is a common scenario. Hydronephrosis without any UTIs, just wait with uroprophylaxis. Cysts and sinuses, there are wide varying presentations, dermoids, thyroglobulus, lot of cysts and sinuses. I'm not going to discuss. Two things I would like to focus. Any cyst and sinus needs excision. There's no doubt about it. Except there are a few things which I'd like to discuss. This is a mucus cyst, which is a very common finding in pediatric age group. People come with these mucus cysts, children bite them. Sometimes it exudes a sort of liquid, regresses. Again, after 1 week, it comes. It is a retention mucus cyst which needs proper surgical excision. So don't, I would suggest don't go for antibiotics or other methods. This will need proper surgical excision. This is something which you will have to notice. Sacral sinus is a common diagnosis, common finding. A lot of anxiety because people think there is a direct communication to the spinal column. Of course, sacral sinus can communicate with the spinal column, but most often what we see is a benign sacral sinus with just a small upturned coccyx. If it is asymptomatic, there is no discharge and there is no pain, wait. Sacral sinus does not need any intervention, whereas the mucus cyst always needs a surgical intervention. So when it comes to simple swellings, the vascular swellings are of course very, very, very tricky. This is one child which I saw last year. This was very much like an abscess. If you look at the picture, it's very stretched, shiny. It was warm and there was some pain. Pain can occur in some of the vascular swellings due to some thrombus or because of the stretching, things like that. And here again, I would insist, go for an ultrasonogram when in doubt and give them this information. It might be a vascular swelling. They'll give you very useful feedback. So vascular swellings mostly won't need surgery. I'm talking about hemangiomas. But one thing is, you'll have to be careful because I've seen situations where such swellings have been incised and it is torrential bleeding and it might even lead to very unfortunate death and other complications. So this is something which was very tempting, like an abscess. I did an ultrasonogram. It came as hemangioma, we have been managing it conservatively. Hemangiomas, as you all know, have three phases. First is proliferative, second is plateau phase, and third is regression phase. Most of them regress spontaneously. You need not worry, except for things like this, which have large hemangiomas, obstructing vision, obstructing feeding, obstructing nostrils. These are the conditions when we have to go in for intervention in the form of drugs. Again, not surgery. So these are the three phases in non intervention hemangiomas, which you have to explain to the parents. So if it is a proliferative phase, you will have the hemangioma growing along with the child. Usually this happens up to 1.5 to 2 years. The mother should be reassured. Imagine there's a hemangioma in the arm. Reassure her, it will grow along with the child, but it won't cause any harm. Whereas a hemangioma in the eye, we'll have to intervene. So tell her about the site. This is not a hemangioma in the arm is not going to bother you. It is going to grow with the child. It will get over. So proliferative phase, perfectly fine. Then it goes for a plateau phase when it is just stable, and then for the regression phase. I mentioned about this because regression phase is something where the drugs work. 70% of hemangiomas regress spontaneously, and the drugs usually work in the remission phase. They induce the remission phase earlier than they just bypass the plateau phase. And the drugs which are commonly used are prednisolone and propranolol. Prednisolone we used to use a lot. Of course, some people are anxious or concerned about the raised ICT it produces. Propranolol again is a drug which can produce bradycardia. So propranolol is something which is the in thing now. The dosage is 1 to 2 milligram per kg per day in divided doses for 6 weeks. This is one course. Most of the hemangiomas which are affecting the airway or oral cavity or the eye, here we use this. Otherwise, we don't bother to use these drugs because these drugs are quite have quite known side effects. And when you are going to start a propranolol, definitely you'll have to get an echo and an ECG done, probably a physician's opinion, and then start a propranolol. Surgery is almost never required for a hemangioma. To sum up the swellings, non-separating nodes without focus, antibiotics for a week or so or even more, then consider FNAC. BCG adenitis, if symptomatic, treat. If skin involved, IND. Hydronephrosis, newborn scan only at 1 week, not earlier. And if there is no urinary tract infection, if the transpelvic diameter is less than 20 mm, you are not going to do much. Put them on uroprophylaxis along with 3-monthly follow-up. Simple swellings can be vascular. Think of them, have ultrasound in mind. And then the last topic is going to be entry and exit issues. Entry issue, I'm going to talk about swallowed foreign bodies, and the exit issues, I would like to touch upon constipation. And this ostrich, as you might know, some of them might know, eats a lot of stones actually. It swallows a lot of stones. We see a lot of children swallowing a lot of foreign bodies. Ostrich voluntarily swallows stones because it needs those stones in the stomach to digest the food which it eats. Birds don't have teeth, right? So these stones help in digesting. They just rub against each other along with the food, and they help in breaking down the food to smaller particles. So you can see ostriches swallowing stones. Don't worry about them. We are concerned about children swallowing stones. Any swallowed foreign body, first thing, assess the child. If the child is not sick, perfectly fine. You are on safe grounds. So you'll have to ask for an X-ray. That is a basic thing. Of course, if it is going to be an opaque foreign body, it is going to be seen. And for asking an X-ray, I would suggest you'll have to be very specific. Include thorax and abdomen from neck to pelvis. This is the request you'll have to ask, because a swallowed foreign body can be somewhere in the neck, somewhere in the esophagus, stomach, or wherever below the diaphragm. That is fine. So ask for a single film which will include from neck to pelvis, because 2 films you might miss something in between. And of course, 2 films have a lot of exposure. So ask for specifically for a single film from neck to pelvis. This is the first thing you'll have to request. You see a foreign body in the neck. Next thing you do is ask for a lateral view. You need to assess whether it is in the airway or in the food pipe. So this is the second thing. So swallowed foreign bodies, generally foreign bodies which cause concern are disc batteries and sharp objects. These are ones which everyone is concerned about. So if it is going to be these risky objects, repeat an X-ray within the 6 hours of taking an X-ray. If it is seen in that same site, probably it is large and it is a risky situation. You will have to intervene. If it is not seen in that same site, it can be in the thorax, it can be a disc battery in the esophagus, in the upper esophagus, lower esophagus. If it has moved, perfectly fine, you are safe. But if it is found in the same site for 6 hours, that is a risky foreign body. That is one thing. And if it is a non-risky material, repeat X-ray after 12 hours. Again, even if it is a coin or something which is found in the same site for 12 hours, that is again an indication that it is probably getting lodged. So most often you don't get these scenarios. I'm just giving you those red flag signs. A swallowed foreign body which has crossed the diaphragm, no worries. However sharp it is, you can be very safe and reassured that it will come out. We get nails, bottle uh, chips, all those things which have been swallowed coming out through the anus without causing perforation. Of course, it doesn't mean you'll have to just send the child off. Have to keep them on observation, preferably in home, or if they are anxious at hospital, allow the baby to pass it naturally. And mostly scopies and other sorts of interventions are not needed. For disc batteries and for swallowed sharp particles, repeat the X-ray after 24 hours. I'm meaning below the diaphragm. If it is above the diaphragm, it is after 6 hours you'll have to repeat. If it is below the diaphragm, do it after 24 hours. If it is moving, perfectly fine. But generally, most of these foreign bodies come out. You can be very happy about it. Definitely, they come out in usually 48 hours. Sometimes it takes a week. I've seen foreign bodies coming after 1 month. So as long as the child is asymptomatic, keep them on observation, follow up, ask them to observe the stools. You'll be happy they'll come out. And constipation, 3 H's, which are indicators or common causes of constipation in children. Hypothyroidism, we are assessing hypothyroidism right, left, and center. So hypothyroidism is not missed nowadays as it was in previous or olden days. Second thing is the habitual constipation. This is the real constipation or the big numbers which we see. Third is Hirschsprung's, which is obviously surgical. Hirschsprung's is mostly you'll be able to make out. Habitual constipations are one which I like to focus. When it comes to habitual constipation, we have a scenario. We have to think about the pathophysiology, because in habitual constipation, what happens is the child doesn't pass. The stool inside is hard, so it gets a lot of fear because the hard stool passes against the anus, creates a fissure, and it creates fear in the mind of the child and creates a fissure and causes bleeding, creates fear in the mind of the parent. So it creates a lot of anxiety. Child avoids defecating. 2-3 days pass by. Again, it gets more solid because all the water content is absorbed in the colon. It becomes more solid, and again it passes with pain. The fissure gets worsened. This is the cycle, vicious cycle. So to break this should be the idea. I would request kindly avoid suppositories in a habitual constipation, because what we have is a hard stool inside. When you put in a suppository, it stimulates and brings that hard stool outside. It actually worsens the condition because the fissure is getting torn bigger. So avoid suppositories. Use your choice, because this is the classification which I have given for your convenience. Use according to the situation. These are stool softeners: lactulose, milk of magnesia, sodium phosphate enema, polyethylene glycol. And stimulants are bisacodyl and sodium picosulfate. Bisacodyl is the Dulcalex and the lactulose is what we commonly use. And of course, we are getting a lot of polyethylene glycol in the market now. And we have the third category called lubricants. They are local lubricants. So according to the situation, what I would suggest is make a choice: one stool softener and one stimulant. Because first the stool has to be softened inside in a chronic constipation before you actually ask the stool to be, you want the stool to be evacuated. So don't use a stimulant like a bisacodyl or sodium picosulfate straight away, especially in children presenting with bleeding per rectum. Use local applications like these gels which are available, which have a lot of pain relief, local pain relief, as well as local antiseptic actions. Use them for first 1 week along with the stool softener. Of course, the child might not pass as you wish, because a stool softener will only soften the stool. It might not bring it out. But for the first week, it's okay if the child passes once in 3 days or even once in 4 days. But when you use a stimulant, you're happy that the child has passed stools, but what has happened is inside it has created a big fissure. So don't use a stimulant straight away in a habitual constipation. Start with stool softeners and local applications. After a week, you know the child, and mother will tell you the stools are a little soft, the child is better, then start using stimulants. But of course, you cannot do with just stool softeners in habitual constipations. You'll have to choose one stool softener along with one stimulant for long-term treatment for about 3 months, regular follow-up, and most importantly, focus on diet. Diet is something which is overlooked in many conditions. Focus on diet, a high-fiber diet, avoiding biscuits, chocolates, chapatis, things like that, and avoiding milk in the night is something which has to be stressed. Milk once in the morning is perfectly fine, because a lot of our children are fed a lot of milk, and that is one common cause of constipation, especially in nights. So some of the entry and exit issues, swollen foreign bodies. The view of X-ray is important. What you ask and what view. Type of foreign body determines whether you have to repeat the X-ray, site of lodgement, and if it is above diaphragm, you have to be extra careful. Repeat X-ray within 6 hours. If it is below diaphragm, repeat X-ray after 24 hours. Avoid suppositories in habitual constipation. Combinations of drugs work better in constipation. So this is the last topic, 2 more slides just. Timing of common surgeries. Pediatric practice generally is exclusive in that this is the only specialty where it is age-based. If you take urology, it is system-based. If you take some other specialty, it might be, for example, disease-based, like rheumatology, where a particular disease is focused. So pediatric is one area where age is a significant factor, because as a child grows, we know there are a lot of changes occurring in the body and the physiology of the body, and so we have to plan few surgeries according to the age. And there are certain situations like phimosis, which doesn't need any specific age indication. Whenever it is symptomatic, you're going for a surgery. Similarly, we have a torsion, testis, or an appendicitis. Again, there is no age or timing of surgery. That is second category. But there is an exclusive group of conditions where timing of surgery is important. So timing of elective surgeries. I've just mentioned the time as well as the surgeries or the conditions. So surgeries which are usually planned in early infancy, that is before 6 months. A meningomyelocele, usually if there is skin involvement, operated in the first week. If the skin is perfectly fine, there is no skin involvement, we usually operate in 1 month. Cleft lip, ideal time for surgery is between 3 to 6 months. There is no need to panic at newborn. Allow the baby to grow a bit. Between 3 to 6 months, cleft lip is operated. Whereas the cleft palate, if you see, goes into the second category. Late infancy, between 6 and 12 months. Because here, we need the oral cavity as well as the facial structure to grow a bit, so that the surgery will be better. We'll have to operate a little deep and we'll be able to handle it better. And undescended testis is something is often confusing a lot of people. The discussion now and the consensus is very clear. For the first 6 months, there is a chance of descent in an undescended testis. But beyond 6 months, the chances of descent is very, 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 very less. So we give usually a buffer period of 3 more months. At 9 months, undescended testis has to be operated. What if you don't do it? Between 9 and 12 months, there are already microscopic changes occurring within the testis, which might ultimately intervene or influence the fertility. And those changes between 9 months and 12 months are reversible. And beyond 12 months, the microscopic changes in the testis become irreversible. So ideal age would be maybe after 6 months, anytime between 9 months. Between 9 and 12 is the maximum you can think about. Beyond 12 months, you don't have an undescended testis without being operated. So 9 months is very specific. You just explain it to the parents. They will know. They'll come back to you, because most of these children are seen in the newborn period, and then it slips out of our mind, because genitals is something which we don't regularly examine. We consult them for other things. So tell them to the parents at the first visit itself, put it into their mind. At 9 months, this has to be operated if it is not coming down. And surgery usually at 1 year is for these cysts and sinuses, because these cysts and sinuses anyway will need surgery. I mean, these cervical cysts and sinuses. But beyond 1 year, there is no specific indication we have to wait, because they might get infected and things like that. Below 6 months, there is a higher risk of anesthetic complications. So 6 months to 1 year is a buffer period. Ideally, at 1 year, you get all these things operated, these congenital cysts and sinuses. And for tongue tie, again, I would suggest at 1 year, before the child develops the speech, better get operated, because sometimes we get children at 5 years, 6 years. We do operate for tongue tie at 5 years, 6 years, but by the time their vocabulary has developed in an altered way, so we'll have to unlearn those vocabulary and then learn these new things. And usually surgery by 2 years is for hypospadias and hydrocele. Here I would insist about hydrocele word, because hydrocele, again, what happens is there's a fluid communicating between the abdomen and the scrotum. So if the fluid is there for more than 2 years, it is actually a high temperature fluid, because anything coming from the abdomen is going to be slightly higher in temperature than the scrotum. So exposure of this testis to this high temperature fluid beyond 2 years is not good for fertility. So that is why by 2 years, a hydrocele needs to be operated. whereas hernia, next operative list. So hydrocele has a buffer period of up to 2 years. After 3 years for umbilical hernia, because umbilical hernia has a high chance of bursting spontaneously. So we usually wait for 3 to 4 years for an umbilical hernia if it is uncomplicated. Again, I would like to insist all these things are conditions or indications for surgery at this year, at these years if it is uncomplicated. For example, you have a cyst which is recurrently getting infected at 6 months, go in early and operate. Whereas an umbilical hernia, similarly, if it is getting recurrently obstructed or producing symptoms, you go in and operate at 1 year. So these are conditions which go on without producing symptoms. These are the timings of elective surgeries. So that is a last slide. I would like to conclude by thanking you all. I realize I would have added just a drop to the ocean. I also realize without it, the ocean would have been one drop less. So I'm happy that I've shared your knowledge and it has added to as one drop to the whole of your knowledge of sea. Thank you so much. That I've shared your knowledge and it has added to as one drop to the whole of your knowledge of sea. Thank you so much.
Nikhil? Nikhil?
Yes, sir.
Nikhil, please include me on the screen.
So I included,
I'm not
sir.
on the screen.
I included, sir. Your camera is off.
Am I on the screen?
No, sir.
No, sir.
I'm not on the screen.
You're audible, sir, but you're audible.
Audible. Okay, okay. Thank you so much. Thank you so much, sir. Hello?
Sir,
Thank you,
you're
sir.
audible, sir. Audible, sir. Audible, sir.
Yes, sir. You can
Am
talk,
I
sir.
audible, sir?
Yes, sir. You're audible.
Thank you, sir. Thank you for the wonderful deliberation of various intricacies of pediatric surgical practice, ranging from management of injuries, starting from simple injuries, suturing, and finally culminating in the timing of surgeries of various benign surgical conditions. Really, you have lived up to your reputation of being a wonderful academician by your wonderful delivering of a wonderful lecture, sir. And I request the participants, if there are any doubts, to put up in the chat box if there is any doubts. One doubt from a participant, sir. Kindly throw some light on your experience with the hemorrhagic cystitis, sir. Elanthirayan, sir?
Yes, sir. I'm just trying to find if I can get that screen.
Hemorrhagic
Yes, sir.
cystitis, sir.
Yes, hemorrhagic cystitis is viral in etiology. This is basic thing which we have to understand because there is no specific indication to use an antibiotic in hemorrhagic cystitis. So what we need to do is one is pain relief. So use the paracetamol. Two is sedation. Third thing is use antispasmodics. I use oxybutynin, propan. Because what happens is in hemorrhagic cystitis, the whole mucosa is inflamed. It is a viral inflammation, viral infection. Whole mucosa is inflamed. It produces a lot of bladder spasms. So the child has severe spasms and they're bleeding, causing a lot of fear in the mind of the parents. So you have to reassure them, ask them, put them in as inpatients, I would suggest, because hemorrhagic cystitis is something not a very sick condition, but something which can cause a lot of concern. Because put them in, admit them, give anti-inflammatory, give them sedation, give antispasmodics in the form of oxybutynin propan. This is enough. Antibiotics are not specifically indicated, but if you are anxious, if you still want antibiotic, go in for a cetirizine. Nothing more needed, sir. It is a viral etiology.
Okay, sir. Palani Raman from our friend Palani Raman from Tindivanam has opined that button batteries we can't wait, and it's ideal to remove immediately if in esophagus. And your opinion on that, sir?
Button batteries are, of course, a cause of concern. And what literature says is go in, once you find a button battery, go in for a SOPI. But we don't find it in practical practice. I would say we see a lot of button batteries every year. If they are staying in one point, definitely I would say, as I mentioned, above diaphragm, if 6 hours repeat an X-ray, I'm talking about an asymptomatic child again. If it is causing pain, if it is causing breathing discomfort, of course you'll have to go in early or you'll have to intervene. If it in an asymptomatic child, if it is a button battery, still you can wait. If it is above diaphragm, do an repeat X-ray after 6 months. What books say is slightly different. I don't really find that in practical practice. And if it is below the diaphragm, we are perfectly fine. Maybe you can reduce the time and maybe repeat an X-ray after 12 hours if you're anxious. But there is no indication to go in and remove a button battery which is actually moving. You can even repeat if you are really wanting to find out something. You can repeat an X-ray every 2 hours if you are really anxious, and then you can see it is moving in the position. So you can be really happy. Definitely, I would say there is no actual indication to go in for a scopy in an asymptomatic cell, even if it is a button battery, unless it is lodged into the same position, location.
Two questions have come up regarding timing of surgery for tongue tie, sir. You already mentioned in your during course of your talk that it has to be operated after first birthday before the child start speaking, sir. And another
Yes.
question from the participant is rock salt in umbilical granuloma. How long and how to use that, sir? Rock salt, similar to that of copper sulfate or something? Anything
No,
different,
sir.
sir?
What happens with rock salt is it is something which just melts actually when you apply. You don't have to wait for 2 hours. If you apply rock salt within few minutes, you can see it is just gone. It won't be seen there. So there is no time duration. You'll have to wait, and you need not have a plaster over a rock salt, because in copper sulfate you put a plaster because the child should not touch the copper sulfate and take it to his mouth. So in rock salt there is no such timing or no just safety precaution necessary. Just apply over it. Only thing is it might not be that corrosive like a copper sulfate. So the pluses it is not that corrosive. The minuses it might need 3 or 4 applications. There is no timing or safety precaution necessary for rock salt. You just ask the mother to keep on applying once daily for a week or whatever it is at home itself.
Okay, sir. Regarding omphalitis, sir, you said topical cetaconazole application for 3 weeks, sir. It's in
Yes.
fact, it's a new point for us, sir. How to justify that point, sir? Applying an antifungal for a probable bacterial infection, sir?
That is something which I learned in practice, sir. Of course, I've gone through some literature because it sometimes goes into that spectrum of intertrigo sort of illness or sort of conditions. So antibiotics, again, I would insist use them for a week of systemic antibiotics, not local applications, oral antibiotics. If they are not working, go for antifungals. I don't have any documented thing like a swab taken to prove working, but this is something which I picked up in my practice. They seem to work very well when these antibiotics alone are not helping.
Okay, sir. Actually, I wanted to ask the question: what is the longest period you waited for a solid foreign body to pass through the was along with the motion, sir? But you mentioned shortly that you waited for 1 month for a child.
Because
In fact,
that is a very interesting. That is a very interesting scenario, sir. Because that was one of my relative children. So they were waiting. They were quite happy and hopeful that they come out, and they had some faith on me. Finally, at 1 month, their faith got emptied, I would say. And so I asked them to get another opinion. So they went to child trust. So they were waiting there for consultation. They called me from child trust because I had sent them there and asked me to put a word to the consultant because they have been waiting from morning to evening. So I put a word to the consultant and then called them back to tell that I've informed the consultant. And while they were waiting in the OP of child trust, the foreign body came out. after 1 month. So they came back without consulting a senior consultant there. There was an interesting story of foreign body coming after 1 month, coming out after 1 month.
Definitely, it's a very difficult to convince the parents, sir. They'll
Exactly.
keep on coming. The foreign body has not yet passed every 2 hours, the second or third day, and sometimes we may have to repeat the X-rays to confirm whether it has passed or not. So it is very difficult, sir. In fact, it is a nice point that we can wait up to 1 month if there is no complaints pertaining to the foreign body injection. And another point
Exactly.
you
One minute, sir. The purpose of my entire presentation was just to reassure you all there is a lot of scope for waiting in many of these pediatric surgical conditions, be it an antenatal hydronephrosis or something like a foreign body, where you just have to be convinced yourself. And I'm a big fan of Ambedkar sir, and most of us are. And he's one person who clearly explains the whole problem and pathology. Because whatever I've discussed with you, I actually tell the parent. I tell them in the case of foreign body, see if it is above the diaphragm, I would wait for just 6 hours. Because it is below the diaphragm, you go back, come after 24 hours, I take it. So whatever I've discussed with you, most of these things I reassure to the patients or the parents. So if we are able to do that, fine. We are quite sure, we can quite sure they come back to us and we can feel safe, and we can ask them, keep them on follow up, and they'll be also happy.
Okay, sir. Another question on regarding the role of testosterone in undescended testis, sir.
It has very specific conditions or indications, sir. In case you have a bilateral undescended testis below 6 months, you can give these hormones. Otherwise, if it is an unilateral undescended testis, the role of hormones is very limited, because the fact that one testis has descended on one side means the other testis could have very well come. There is no hormonal deficiency. And generally speaking, the role of hormones have come down drastically. Even when I was doing MCh, there were few people using hormones. But nowadays, we just wait for 6 months, allow the testis to come down, otherwise go for surgery. Role of hormones is very limited nowadays in undescended testis.
How do you manage
Yes, sir. The audio is off.
Sir. Okay. A call came in. Am I audible, sir?
Yes, sir. Yes, sir. You're audible.
How to manage tongue injuries medically, sir? Like dermasil-like thing, anything that can be applied over tongue injury?
No, sir. No, dermabond or whatever, the tissue adhesive doesn't work when there is moisture. Actually, the whole area has to be dry. So even when you are using it for a skin, I would like to insist that you'll have to apply it over the skin, not between the two cut edges, and try to stick it like we stick an envelope. So actually, dermabond doesn't work on these wet surfaces. So tongue injuries or any oral cavity injuries, as I mentioned, only two indications, and they are very specific indications. If it is bleeding, no way you are going to manage conservatively, do a surgical, that is suturing. And if it is a hanging flap, definitely it is not going to stick. Otherwise, it will perfectly get aligned, and we don't have a problem of osmosis or infection, as I mentioned, in the oral cavity. So two indications will be bleeding and a hanging flap in oral cavity injuries. Otherwise, you can perfectly manage with drugs.
Dr. Saravana Kumar has asked for the description of how to apply surgical glue, sir.
That is actually has to be demonstrated, sir. You can give sir my number, or even I can do a demo and put a video of that in, send it to you. You can share it in your group, because that has to be demonstrated. It is not that simple to be explained now or demonstrated, sir.
I understand, sir. But regarding whenever we encounter a case of, when we come across a case of urinary tract infection, for boys, our main focus is on to rule out phimosis, and for girl babies, definitely, naturally, for every baby, we will be looking for vulval synechia, because as far as we pediatric physicians are concerned, vulval synechia often predisposes to UTI. So you said it is a very innocuous usually, but sometimes it may lead on to, it may precipitate urinary tract infections.
So what is the question, sir? How to?
No, sir, no, sir.
Just your comment on that.
Regarding bulbal synecdoche predisposes to urinary tract infection often. That's what I want to emphasize.
Okay. I take it as an observation from you, sir. Thank you.
That Arun, you want to add anything or you want to comment
Yes,
anything?
sir. Yes, sir. I want to just highlight some points which sir stressed it, sir. Especially, sir clearly delineated mucosal injuries and tongue injuries which should be referred to the surgery and which can be managed in OPD, which was very useful, sir. And the next thing was the use of antibiotics in scalds, sir. Actually, the very behavior of every of the physician is that after managing every scalds, we immediately prescribe an antibiotic. That's the thing we all have the practice. So, sir clearly described about the use of antibiotics in scalds and when not to use and when to use antibiotics, which was very useful, sir. And again, the use of choice of antibiotic in the abscesses, sir. We have the common practice of using amoxiclav left and right over here for the management of abscesses. And sir clearly stressed that point of using cloxacillin, which was very useful for us, sir. So the use of amoxiclav can be reduced in the cases of abscesses. And again, the next point was the usage of paracetamol in mesenteric adenitis, sir. Whenever we see mesenteric adenitis, we just prescribe antibiotics and we forget to prescribe the paracetamol along with antibiotics in case of mesenteric adenitis. Actually, the prescription of paracetamol is very, very, very important in case of mesenteric adenitis. Even a single or 2 doses of paracetamol will relieve the complete pain in mesenteric adenitis, which is very useful, sir. And the next point was the timing of ultrasound in case of neonatal hydronephrosis, which was very useful, sir. Every mother and the parent will be anxious and they take the child immediately after delivery, come to the pediatric surgeon wanting to do an ultrasound. So that point was very clearly made by sir. That is the first 3 days there will be an oliguric phase. So the ultrasound will falsely reveal a hydronephrosis. And we have to do a neonatal ultrasound only after 3 days, which was very useful, sir. And the last point was regarding the constipation, the use of stimulants and the stool softness. Straight away, we go ahead with the use of stimulants mostly, which should be avoided in our clinical practice. And the combination of both stimulants and the stool softeners should be used, which was clearly stressed by sir, which was useful. The last point was the timing of surgery in undescended testes, sir. The most common problem we encounter in peripheries like here is most often after the delivery, the gynecologist or the obstetrician treating will see the child and tell the parents that there is no problem. It will come off downwards as the child goes by. This is a common advice given by the gynecologist, sir. Usually they bring the child after 2 years or 3 years to the pediatric surgeon stating that இது ஒன்றும் செய்யாதுன்னு சொல்லிட்டாங்க, அது அதை வைக்கல வந்துரும்னு சொல்லிட்டாங்கன்னு தான் அட்வைஸ் பண்ணது. So common problem we encounter here, sir. So that point was clearly stressed by sir, which was very, very, very useful, sir. So yes, these are the points which I want to highlight, sir. Yes, sir.
Sir, thank you so much for
thank you, sir.
giving a beautiful sum up of my talk, because
yes, sir,
this
sir.
is something I actually missed. I usually do, and you have beautifully enumerated all those important points. Thank you so
yes,
much.
Sir. These points were very useful for a regular practitioner, including a pediatrician and gynecologist and a general practitioner, which will be very, very useful for us, sir. Yes, sir.
Yes, sir.
Thank you, sir. Thank you very much, sir.
Some years before, during one conference, one speaker was telling the biggest present a male baby can have on its first birthday is to have both his testes at the scheduled place of his scrotum, sir.
Yes, sir. Yes, sir. Yes, sir.
Thank you, sir. Thank you, sir. Thank you, sir. And the last question from Palani Raman: frenulum injury, your approach to stop recurrent bleeding, sir.
Sorry, sir.
Frenulum injury, sir. Lip frenulum injury, and if the bleeding is recurrent, and what can be done?
I would like to share my experience on frenulum injuries. I'm not sure whether sir is asking about the oral frenulum or the genital frenulum. I assume it is the oral frenulum. Oral frenulum has an anatomical advantage in that there is always pressure applied automatically, because between the gum and the upper lip, the frenulum is just buttressed, or it is just there. So when you leave it alone without disturbing, what happens is it actually stops bleeding. Only when we are anxious, and when the mother is anxious or the physician is anxious, lift up the lip and keeps on seeing, then you have a bleeding. Frenulum injuries have this beautiful anatomical location where they automatically stop bleeding. But if you, I've never encountered a frenulum bleeding needing a suturing in the anesthesia, under anesthesia in a theater. But if someone has seen that, well, it has to be treated just like any other oral cavity injuries. If it is bleeding, it has to be sutured. But in my 20 years, I've never seen a frenulum bleeding going to the theater because of the location where it is conveniently located between the bony upper mandible, as well as, sorry, upper maxilla, and between the upper lip.
Thank you, sir. Thank you. Many thanks for your wonderful lecture. Thank you, Arun Kumar, for chairing the session.
Yes, sir. Thank you, sir.
Thank you,
Sir, thank you, sir.
Thank
Thank
you,
you very much, sir.
my dear Nikhil, for helping me to conduct the CME. Thank you all the practitioners of Virudhunagar district and throughout Tamil Nadu for coming and participating in this wonderful session. On behalf of Virudhunagar District Pediatric Forum, I immensely thank you one and all for your active participation to make this webinar a grand success. And let us meet after 2 months in at another wonderful program. Thank you, Elanthirayan sir. Thank you, sir. Thank you,
Thank you,
so much.
sir.
Thank you, sir.
Thank you, sir. Thank you very much. Thank you.
Thank you.